Hey everyone, it's MedTalks, and welcome to a high-yield AMC masterclass. Today, we're tackling hoarding disorder. Look, if there's one mistake that I see trip up candidates in the psych station, it's this one right here, mixing up hoarding disorder with OCD. It costs people easy marks, and today we are going to make sure you are not one of them. So, when a case like this pops up, what's the first question that should be running through your head? Is this person just a messy collector, or are we looking at something way more serious? Nailing this distinction, that's the core challenge both for the exam and for real-life practice.
Okay, let's get right into it, because this slide is pure gold. If you take one thing away today, let it be this. Hoarding disorder is egocentric. What does that mean? It means the patient thinks their behavior, saving all this stuff, is totally reasonable. It makes sense to them. But OCD, that's usually ego dystonic. The patient is tortured by these intrusive, unwanted thoughts. They know it's not rational, and they hate it. Get this difference down and you are well on your way.
All right, let's make this real. We're going to meet a patient, the kind you'd expect to see in a classic exam vignette.
You are going to hear some version of this, I promise you. I can't possibly throw that out. It might be useful someday. And listen, this isn't just them making an excuse. This is their core belief. It's what drives the whole thing. To them, it feels completely rational, which is a perfect example of that egocentric nature we were just hammering home.
Okay, so as you're building this case in your mind, you're ticking off boxes, right? Here's what to look for. First, excessive acquisition. They aren't just keeping stuff, they're constantly bringing more in. That leads to, you guessed it, cluttered living spaces. We're talking rooms you can't even use anymore. And if you try to get rid of anything, you'll see some major distress. Now, a huge red flag for the AMC is their poor insight. A lot of the time, they just don't see the problem. And this is critical. All of this creates very real dangers. Think fire hazards, falls, terrible hygiene, you get the picture.
Okay, so we've got a pretty clear clinical picture forming. Let's switch gears now and look at the formal criteria. How do we lock in that definitive diagnosis?
So, according to the DSM-5, here's the official word. We're talking about a persistent difficulty in getting rid of possessions. And it doesn't matter what they're actually worth. Why? Because there's this perceived need to save them, and the very idea of discarding them causes genuine distress. It's really that combo, the difficulty and the distress, that elevates it to a disorder.
All right, time for a super high-yield mnemonic that's going to save you on exam day. Just remember the ACID test. A is for excessive acquisition. C is for clutter that's so bad it blocks off living areas. I is for impairment. It's messing up their life, their job, their relationships. And D is for that severe and persistent difficulty discarding things. If you can run through ACID in the exam, you've nailed the core diagnostic features. Simple as that.
So let's take a quick look at the numbers because this stuff matters. The lifetime prevalence is somewhere between 2 and 6%, so it's not as rare as you might think. We often see the onset start in adolescence, maybe around 11 to 15 years old. But it really becomes a problem in midlife, in a person's 30s or 40s. And a key thing to remember is that it tends to get worse with age.
Okay, diagnosis made. Now what? What's our game plan? This is absolutely crucial, so let's walk through the management blueprint, your first-line approach, straight from the Australian guidelines.
You've got to think of this as a step-by-step hierarchy. And step 1, the absolute gold standard, is hoarding-focused CBT, cognitive behavioral therapy. And ideally, you're doing it in the patient's home. You have to tackle the problem where it lives. Next up, step 2, is motivational interviewing. This is so important for getting past that poor insight we mentioned earlier. Then, and only then, do we think about medication as an adjunct, things like SSRIs. And finally, you absolutely have to bring in a multidisciplinary team. We're talking occupational therapy, social services. You need that support to manage safety.
And here is a massive clinical pearl for your exam. Seriously, write this one down. There is no medication specifically approved for hoarding disorder. None. The meds we use, like SSRIs or venlafaxine, are off-label. They're mostly there to treat other stuff that's going on, like depression or anxiety. The main event, the primary treatment, is CBT, not the pills.
Okay, let's talk about the classic exam traps. This is where people get tripped up and lose easy marks. I'm about to show you a question that's designed to do just that, to separate the people who really get it from those who are just guessing. You're not going to fall for it.
So, picture this on your exam paper. The question is, which of these is the least likely feature of hoarding disorder?
Okay, let's break down the options. Option A, a strong belief that their possessions are useful or valuable. Option B, unwanted intrusive thoughts about items being contaminated. Option C,
clutter that makes it impossible to use a kitchen or bedroom. And option D, significant distress when they're faced with getting rid of things. So which one is the odd one out? Have a quick think.
And the answer is B. This goes right back to what we said at the very beginning. Unwanted, intrusive thoughts about contamination, that is classic OCD. It's ego dystonic. The person doesn't want the thought. The other three, the belief in value, the clutter, the distress, those are all core ego syntonic features of hoarding disorder. You see how they try to catch you out by borrowing a feature from the main differential? Sneaky.
All right, that was a lot of info. So let's boil it all down. Here are your top 3 takeaways. These are the non-negotiable, must-know facts for the AMC.
Right, let's lock these in. Number 1, the key differentiator, hoarding is ego-syntonic. OCD is ego-dystonic. Got it? Number 2, management. The gold standard is home-based, hoarding-focused CBT. That's your first line. Meds are just helpers. And number 3, red flags. You always have to assess for poor insight and the big safety risks. Falls, fire hazards, poor hygiene. You master these 3 points, you're going to be in great shape for the exam. If you want to dive deeper, all the detailed study materials for this are up on PayHip and Paystack. And for more quick tips, find me on TikTok at MedTalks_AMC. All the links are right there in the description below. If this helped you out, do me a favor and hit that like button, subscribe so you don't miss the next one, and drop any questions you have in the comments. Thanks for watching, and I'll see you in the next explainer.